Hello, everyone. I'm Mark Plaster, and this is EP Talk, the place where emergency physicians come to talk about important stuff. And my co-host today is JD Landon, and our guest is Marcus Kaplan. Why don't you tell us a little bit about Marcus? And I know you guys work together, and I'll give it to you, and I'll chime in when I seem to understand what you're talking about.
Thanks, Mark. So this is going to be a confusing one today because we got Mark and we've got Marcus. So Marcus is our emergency medicine PharmD at my shop, and he's a legend. When Marcus is in the department, everybody gets excited. Marcus also is like the critical patient whisperer in the sense that he will find them. If there's a critical patient, he just all of a sudden just is there and knows and he's basically knows what's going on and what needs to happen. And so he hails from UNC and Duke, and we're super, super lucky to have him in our emergency department. And I'm super excited to have him on the show today to talk about some very exciting cardiac arrest data. So Marcus, thanks so much for coming on. Tell us a little something else about yourself.
Thank you very much, gentlemen. I appreciate that overly enthusiastic introduction. But JD, you covered a lot of it. You specifically said that I was from both UNC and Duke, which I guess is technically true, but I do have to state for any college sports fans who watch the show, I was a Duke fan first and foremost and remain a Duke fan. I just happened to spend a few years in enemy territory while I was in pharmacy school.
We won't hold it against you. Somebody else probably will, though. So yeah, today we're going to talk about this super exciting paper in resuscitation. It's titled Early Intramuscular Adrenaline Administration is Associated with Improved Survival from Out-of-Hospital Cardiac Arrest. It's from this awesome group out in Salt Lake City, Utah. It's a pre-hospital study. And I'll do a real quick 60-second overview of the paper, and then we'll hear from Mark. So the population is all pre-hospital cardiac arrest patients, adults, non-traumatic. The study design was a before-after study. So they basically looked at a group of patients who received the standard IV or IO administration of epinephrine. The pre-group was from January 2010 to October of 2019, and then the post-intervention group where they started to administer epinephrine via intramuscular in the lateral thigh began in 2019 to 2024. They enrolled around 1,400 patients. Primary outcome was survival to hospital discharge, and then secondary outcomes where they basically wanted to know how long did it take for the actual administration of epi once the EMS team arrived, as well as neurologic survival. We'll just jump right into it. Results showed that in the IM cohort, in the group that received IM administration of epinephrine, there was improved ROSC at hospital admission, improved survival at hospital discharge, as well as, and this is the real zinger, is they noticed a neurologic survival benefit in the intramuscular adrenaline group, which is a big deal in cardiac arrest literature. To be able to make a statement of benefit in neurologic survival is no joke. Mark, what do you think about this? You've been doing this a long time. What do you think?
I have to say that when you sent this paper to me, it was like a very distant, foggy dream, because both of you guys were not born when I started in emergency medicine. Okay. And at that time, we were doing intracardiac epinephrine with spinal needles. They were massive. And it was one of the coolest things in the world that the emergency medicine residents could do, is pull out this big thing with a spinal needle on it and jam it into the fourth intercostal space. All the way, you would pull out, you got blood because you're supposed to be in the ventricle, but I don't know where you were most of the time. Okay. Shove all this epinephrine in there. It was like, I got the charge. I don't know about the patient, but most of the time I got the massive charge of giving this guy the epinephrine because they thought we were doing this. We thought we were helping him. And of course, over time, we all looked and said, I don't think we probably have as many lacerated coronary arteries and other complications. And so slowly but surely, they took that away from us. But I will say that it was seen in two movies, Pulp Fiction. It was in Pulp Fiction. I'm sure you guys have seen Pulp Fiction, where he jams a cardiac needle in there, thinking that he's gonna do this for a heroin overdose. For crying out loud, what happened to Narcan? He was supposed to be putting epinephrine in there. and the rock. It was in the rock. He got a VX exposure. Instead of giving him atropine, like his spark gave him, he gave him adrenaline, intracardiac adrenaline, and so that's my contribution, a flash from the past. It didn't help for the rock, and it didn't help in Pulp Fiction, and it probably didn't help a whole lot when we were giving intracardiac either. I'm actually excited because it looked like there were times in which you obviously were juicing the patient up. And if you just accidentally got it in the right place, you might actually give them enough juice to get started. And so the idea is a good idea. And we're going to talk about the idea of pre-hospital as opposed to in the emergency department. And I think that all of our studies and all the way we look at this, factored into that needs to be time. How quickly do they get epinephrine, however they get it, whether it's IM, IV, IO, however. And I think that we'll talk about it. You guys talk about the study, tear it apart, but keep that as a thought hanging out there is how quickly can we stimulate them with epinephrine?
I love the background, Mark. And you can make the argument that you guys were onto something and that putting the epinephrine right where you're hoping to find the benefit, it's primal, but it makes sense. Epinephrine and its use in cardiac arrest is a huge topic, obviously, and a controversial one at that. So in this study, just to be a little bit more specific, they used a 5 milligram intramuscular adrenaline dose that it seemed like they extrapolated for some of the anaphylaxis literature. Seemed like the max amount that you can put into muscle belly is about 5 mil before I guess you have issues or concern for necrosis. And so it seems like that's where they came up with the dose. But epinephrine in cardiac arrest, we currently use a milligram IV or IO. Where'd that come from? Is there something special about a milligram?
I am not aware of anything in particular that's special about a milligram or anything that's special about your every 3 to 5 minute dosing range. And ever since I've been in the medical world, that's always been the dosing and the recommendation. And I guess I've come to accept it as dogma, if we're being honest.
It's interesting because to my knowledge, we don't have any kind of multi-tiered studies comparing placebo versus 500 micrograms, 750 micrograms, 1,000 micrograms in cardiac arrest. Like the data doesn't exist to my knowledge.
Well, it's like you guys have said before, though, the yield on these studies is so small that the study size, the population that you're going to study has to be in the thousands in order to really see anything statistically significant. And so that's the reason why they've done their best guess and then look at it and see how it works. Throw it against the wall, see if it sticks.
Yeah, it brings up an important point because the question, I think, to you, Marcus, is do we think dose matters?
So that was, and you already pointed this out, but right, the dose in this particular study was 5 milligrams intramuscular because they didn't feel like they could give a larger volume into that muscle tissue, unless I suppose you want to stick them in both 5s simultaneously, then you can get to that 1 milligram or 10 milligram dose. And like you said, in this paper, and I tried to find where they got this, but in this paper, they stated that they were able to derive from anaphylaxis intramuscular epinephrine dosing that a 5 milligram intramuscular dose would be equipotent to a 500 microgram or 0.5 milligram IV dose, which does make you wonder if they wanted to do it consistent with what our current ACLS algorithm suggests, shouldn't they have given 10 milligrams over perhaps 2 injections? I tried to find where they found this extrapolation and I came up short. But does the dose matter? I'm not really personally convinced that it does. I think to an extent, however many hundreds of micrograms of epinephrine we're injecting by IV push, it's all jet fuel in the veins at that point anyway. And to an extent, how much more can you saturate those alpha receptors on your vasculature with 200 versus 600 versus 1,000 micrograms of epinephrine at a time?
So am I hearing you say that basically there's probably a max threshold benefit at which your receptors are really not going to respond anymore?
Yeah, that's theoretically true of any medication. You give it a large enough dose, you're not going to be able to bind anymore because there's no more receptor that's lacking a substrate. And then especially if you consider, it is true that when you give it IV push, it goes away fast. But if you consider that we're giving it every 3 minutes, I think without a doubt, we're completely saturating every receptor possible. So to an extent, dosing is maybe somewhat arbitrary, if you ask me.
Sure. And just as background, one of the largest trials, right? We have paramedic trial, which really didn't show any change in neurologic survival between placebo versus epinephrine, which is what makes this paper really pop, is that they actually saw roughly about a 4% absolute difference in neurologic survival between the two groups. Marcus, tell us a little bit about your understanding of the pharmacokinetics and pharmacodynamics to all these dumb ER doctors when we're talking about putting this in the vastus lateralis versus IV. I imagine there's like volume of distribution concerns. Like most of our local patients that we're taking care of in cardiac arrest, they're not small people. They're certainly not pediatric size. And I would say 15% of our patients are actually their ideal body weight. Do you think that's playing into this?
Yeah, that is an interesting question to consider. I don't think we got demographic information in this study down to the level of patient weights and BMI and that sort of thing. But yeah, just thinking from a basic pharmacokinetics and dynamics principle standpoint, obviously giving a drug intravenous is going to get it right to where it needs to go a lot faster than basically by any other route. And of course, I think sometimes people forget, and it sounds silly to say this, but I think sometimes people forget that when a patient's in cardiac arrest, the only circulation they're getting is us banging on the chest. So for sure, cardiac output and circulation is at a much reduced rate compared to normal patients with a pulse. That all being said, we know from anaphylaxis, even anaphylactic shock experience, that intramuscularly administered epinephrine still works pretty fast. And so I think it's feasible, and is it physiologically, believable that giving an IM dose in the setting of cardiac arrest is going to have a benefit? I still think yes. And especially when you think about a large muscle that's highly vascular, like the thigh muscle, I do think perhaps there's a slight delay compared to giving it IV. Honestly, I'm not sure about IO. I think that's a whole other can of worms. And we probably do need to talk about that, considering that in this study, the alternative group was getting either IV or IO, intraosseous med administration. Obviously, if you put IV and IM side by side, the IV is going to get there quicker, but you have to factor in the time it takes to get that access as well.
Right.
I think there's lots of literature in lots of different realms beyond just cardiac arrest where, that's the same principles apply there.
I think that lands us squarely on table 1, right? Which is this study population and some of what I would consider are the things that I was concerned about looking through this. And so just to highlight a couple things, the groups were mostly balanced, I would argue. One of the major things that I noticed was bystander CPR between the two different groups. So the bystander CPR rate in the IVIO cohort was 56% versus 69.8% in the IM cohort. So roughly a 15% difference in bystander CPR, which we know for sure and has been consistent through all cardiac arrest literature that bystander CPR leads to ROSC, leads to survival to hospital discharge, as well as neurologic survival. And so although they say that they did logistical regression analysis and adjusted for this as a confounder, as far as the two populations go, it's a pretty significant difference in the two different groups.
It makes actually good sense that bystander CPR would improve the effect of IM epi simply because you've got circulation. And when you don't have bystander CPR, everything starts to shut down. And then you're going to have it stuck in the muscle. But if you have effective, aggressive, early bystander CPR, you've got blood flow. It may not be great, but you've got it. And so I think that's completely understandable. And it's not intracardiac, but it's still flowing. Okay, so that's the idea. I think that's where you're going to see the effect.
Yeah, I think that makes sense. And then back to your point earlier, Marcus, about time, and you as well, Mark, the two groups here. So the IM cohort from time of EMS arrival to IM dose was 4.3 minutes versus the IVIO group was 7.8. So almost a doubling from roughly 4 to 8 minutes. And 4 minutes, right, when we think about cardiac arrest pathophysiology, 4 minutes is enough time to get you well past the electrical phase to the circulatory phase.
Yeah.
And so maybe, like you're saying, the combination of bystander CPR where there's still some low flow plus early administration of IM, maybe that's where we're seeing some of this benefit. Is that believable, Marcus? What do you think?
Yeah, I think to me, that's one of the most noteworthy things to compare between this study and the Paramedic 2 trial that you've already alluded to. So I think I got to say, I think I specifically remember, JD, you told me after you read the Paramedic 2 trial that you're never going to give epinephrine to another patient in cardiac arrest again. Just sure that it had no benefit at all.
You got to question it. I'm still on the fence about epinephrine.
But the biggest difference that I think really matters, we've already alluded to it several times today, but really time is key. And if you look at that Paramedic 2 study, I think it was an average of about 15 minutes, give or take, before patients got any doses of epinephrine or placebo, whichever the case may be. And so the difference here, where we're talking about less than 10, even as low as 5 minutes, that seems to me like a pretty clinically significant difference in terms of the overall care being provided to the patient. So is there any magic in the intramuscular administration necessarily? Perhaps not, but really is it that time to first dose that makes all the difference?
Right. And the IM methodology helps it to be faster. I mean, the point of it is you have lesser skilled people actually shooting in an IM. Virtually anybody can do that. Okay. Not everybody can do an IO, and certainly not everybody can do an IV. And so that builds in time, and I think that may be the factor. Getting the medication in there in a timely manner is the key.
Yeah, so I should, just to be fair to the paper and be accurate here, the time from emergency call to first administration was 12 minutes in the IM group versus 15.3 minutes in the IVIO cohort, right? So you're right, Paramedic 2 trial, their mean was, I think it was 21 minutes, if I remember correctly, Marcus, about 21 minutes. So they're definitely faster in this trial by 8 minutes and that's from the call, which really matters, right? And I think that might be on face value, maybe the greatest takeaway for me from this, and maybe where I get the most excitement about the potential that this could be a real finding in neurologic survival, is we could train lots of people to give intramuscular epinephrine in the same way that people are walking around with their anaphylactic dose with their allergies. You could theoretically have this stored right next to the AED. Every AED could have a little injector pen for cardiac arrest dose, which from a public health perspective, it's a big deal. It could have a significant change if we think this is real. If we think this is real.
But you are going down exactly the same pathway that I was thinking, which is right. For years, we've been talking about the value of external defibrillation of a shockable rhythm, and we've trained lay people everywhere about using AEDs. Right. So, right, if all of that infrastructure already exists, if you believe this is real, then perhaps it is just as simple as let's create a formulation of epinephrine that's going to be shelf stable and able to be withstanding whatever temperature and environmental considerations or those AED boxes are being exposed to. Yeah. Easier said than done, but I'm also not a pharmaceutical manufacturer, so someone could figure it out. And let's stick a dose or two of epinephrine in all those AED boxes all around the world. Perhaps that's another step forward, perhaps in advancing the kind of layperson ability to handle a medical emergency and take care of a patient in cardiac arrest. We know out-of-hospital cardiac arrest is devastating, and anything we can do to start the process a little faster has got to, you would think, improve situations for the patient.
The military taught us buddy aid, and buddy aid, having been at a shock trauma platoon in the Marine Corps, I can tell you that buddy aid made the difference of so many soldiers in the field. We laugh about it, but the truth be told, that really is probably the greatest impact is how long is it before somebody receives care? And hey, 0.1% or 3% or 5% is a big number when it's you.
What other thoughts do you have, Marcus?
I think we talked a little bit about how much you want to buy into the statistical findings of this paper. How much do you want to buy into the fact that it's, at the end of the day, it's still a small difference between groups. And we've already touched on this, but the numbers for any good outcome are always small in these out-of-hospital cardiac arrest kinds of discussions. And even a couple percentage point difference, it seems not only statistically significant, but to me, clinically significant as well.
Yeah, and so we can run through that real quick, just so that everybody's on the same page with the outcomes they saw. And so for their groups, the IVIO cohort for neurologic survival, they had 6.8% and 9.8% in the IM group. So an absolute difference of about 3.6%. And so it's impressive. They did a intention to treat analysis. And so they had about an 89% protocol compliance, which means about 10% of the patients didn't actually get what their cohort was prescribed. And so when they do the intention to treat, the benefit is still there. The absolute difference actually went up to about 5% when they did the intention to treat. But the per protocol analysis was at 3.6%. And then when they went and they specifically took out the non-compliant cases, the benefit still remained with an absolute difference of 4.2% favorable neurological outcome in the IM group. So kudos to the authors. They definitely, I think, with the retrospective pre-post design, I think they gave an honest look, right? So they looked at a per protocol, they looked at an intention to treat, and they even removed the protocol violations to try to see, was the benefit still there? And it was still there. There was still a positive, statistically significant benefit with neurologic survival in all their varied analysis, which, as much as it pains me, I have a hard time believing on face value that IM epinephrine given 4 minutes sooner is really going to have a 4 to 5% favorable neurological outcome. But I'm more than happy to be wrong about it.
Yep. I have a question for you because I didn't see it when I was looking through the study. Did they look at body habitus?
We have some basic demographic data, but at least in here, it was not reported. BMI was not reported.
Yeah, I think it actually would be a very important thing to have, because some of our patients, an IM becomes a sub-Q. It depends on how big they are. And so I don't know how long these needles are, whether they're auto injectors, or they're 1 inch. Are they getting through this adipose tissue or not? So that would be an important thing to me. I think that those numbers could shift significantly if we have so much obesity walking around. So I think you have to answer that.
Yeah, and as Marcus had said before, one of the things that I thought was interesting that I personally didn't know is there's a pretty significant proportion of the time when the IO fails, which I personally didn't realize. And so that also be contributing, right? So this is really not a head-to-head IV versus IM, because a significant proportion of these patients actually received IO. And if a proportion of those had IOs that were really not effective or not flowing well, it was really an epi versus no epi, or IM early epi versus no epi, which still just blows my mind that they found neurologic survival, because the Paramedic 2 trial was tens of thousands of patients, right? It's a massive undertaking.
Almost.
To not find a significant difference in neurologic survival.
I think to play further along on the side of maybe the study really was good and could have even been better. So not only did the majority of patients have IOs, which potentially, and there's studies out there, if you just look, probably retrospectively, but if you just look at everyone who got IO epi versus everyone who got the IV wins. But not only that, but you alluded to this earlier, the post group was all during COVID times in this study. So who knows the kind of unmeasured effect that COVID had on the whole post population, and yet they still did better than the pre group. Now, you could factor in the time it takes to get all the PPE on if you're the first responder going to the site of that patient, and perhaps that made it take longer. That 12 minutes you were alluding to earlier, maybe it would have been 10 minutes if this was non-COVID times. Not to mention if COVID played a role in the cardiac arrest or not, if it was more of a respiratory concern or what have you. Obviously, you always get to play the what-if game with these kinds of studies, but that's a what-if that possibly could have even made the study have a stronger outcome in favor of the intervention.
Yeah. All the studies that have come out in this kind of 2019 to 2021 era, I don't think anybody has really come up with a good way to basically control for the massive confounder of COVID and what it did to our health system, and how we were taking care of cardiac arrest patients at the time, what percentage of the patients in that group had an arrest related to COVID and went on ECMO. They did say, because the shop that this was done at in Utah was an ECPR program, but the rates of ECPR were similar between the two groups. And so theoretically that shouldn't have changed anything. But yeah, lots of questions. If nothing else, I imagine that the world of cardiac arrest research is going to be very intrigued by this. And I imagine that people with deep pockets are already planning some pretty large RCTs to take a closer look.
One of the things that I think that you really have to think about with this, and it goes back to our generational way we did things. 30, 40 years ago. Okay. When I started into this, we were doing a lot of things that was any port in a storm. Okay. If you, obviously you couldn't do things that were going to kill live patients. Okay. But when patients had very, very poor outcomes predicted, I just, we were, like I say, we were doing some pretty crazy stuff and we got some decent results out of it. I think that your generation is looking for the gold standard in every single thing that we do. And you may not find it. You just may not find it. You may have to try it and try it for 5 or 10 years. And then you may not know exactly, well, was it better CPR? We did a podcast on using ultrasound to guide a hand placement for CPR. And oh my gosh, we got better outcomes because we put our hands in the right place. Okay. And there's all kinds of things that can help that. And so I was pretty excited about this. I was a flash to the past, but at the same time, I'm saying that your downside of giving IM epinephrine is negligible.
Sure.
And yes, we'd like to see the perfect study show this, that it helps. But I would be inclined to lean toward, seeing to try it and see if over time we see an increase in ROSC and the neurologic survival, which the study suggests.
Yeah. You touched on a really important point there, Mark. And when I was talking about this study with some colleagues, we actually had a student who was with me on a rotation in the ER. He did a journal club presentation just amongst the pharmacy staff on this study. And the very first question that one of my colleagues asked after he was done talking about it was, so why shouldn't we do this? What's the downside to giving IM epinephrine? And no one could really come up with a really strong answer as to what's the downside.
I should just say, just so our listeners have clarity before hopefully y'all go and take a look at the article yourself, but the two groups, so the IM group, they just got one dose of IM. So they got one dose of IM and then continued on with IV or IO. So it's not like they were giving continued IM injections over and over. It's just one initial dose of IM. And you can imagine if you've ever been with a paramedic or on the scene, you go into someone's house, it can be really chaotic. And so the idea that we're asking these EMTs and paramedics to get the patient into a position and location where you can even start CPR, right? Get somebody on the airway, get access, give epinephrine, make sure you're feeling for a pulse at your first pulse check, get the pads on, make sure it's not a shockable rhythm. It's a lot we're asking these guys to do, oftentimes in really brutal circumstances when families are screaming, yelling, the patient's maybe 400 pounds, and just getting them into a place you can start CPR is a chore. Yep. And from all of those perspectives, you can definitely see why not have the first dose while you're just trying to get things set and figured out what's going on. You realize they don't have a pulse. You realize they're not breathing. Give your first dose of IM and then get set up for your resuscitation. We should probably have an EMT and paramedic come on and get their opinion to see if this would be something that they think would be helpful for them, or another thing they got to worry about, or is this going to be annoying for them if they have to draw it up into a separate thing, if that's a whole different process for them, if it really needs to be the anaphylaxis type injector.
While you were saying all that stuff, that was the first thought that came to mind is, okay, so you are thinking about 75 more things when you're on the scene getting started with cardiac arrest care. So let's just add one more wrinkle. Now you have a different route and a sharp needle and you have to draw it out of a vial. So it's true. Absolutely. Those are considerations.
And I have all the respect in the world for these guys. And I try to take a moment to appreciate them every time they walk into the ED, because inevitably, right, they've given their blood, sweat, and tears working this patient for who knows how long, dealing with the family, managing the scene, making sure it's safe. And then they come in and we fiddle around with our ultrasound for 5 minutes and call it right after they just gave their blood, sweat, and tears for it for 30 minutes. Anything that we can do, I think, to make their lives easier and simpler and faster, certainly something worth looking into.
But I think but you mentioned something though, that I think their heart is, if you give them another thing that they can try, they'd be all for it.
Yeah. I have to imagine that they would.
Yeah, they'd be all for it, especially if it's an auto injector. Now, drawing something up in the middle of that's different. You got to get in the unit to do that oftentimes, just to get light and be able to see in hands, that sort of thing. But an auto injector and a stab, which we do in combat, so you could do that pretty easily. And I think they would go for that.
Marcus, what are we missing? What should we have talked about that we didn't talk about?
I mean, the only other thing that I was going to add is just the landscape of literature in terms of medications used in cardiac arrest is not overwhelmingly impressive. I'm a pharmacist and I regularly teach talks, to nurses, to physicians, to other to other groups where I'm asked to come and talk about cardiac arrest medications because people get anxious. There's so many meds on that code tray. What are they all for? How do we give them? And every single time I give this talk, the very first thing I say is, I'm here to tell you that the medications we use in a cardiac arrest are nowhere near as important as CPR and defibrillations, because by far, those are the two interventions that have shown definitively to improve outcomes. Everything else we do, I'm not really certain we're actually helping the patient. Even the epinephrine, if you read the Paramedic 2 study, maybe you're not so sure it's even worth doing in the first place. Anytime we can have more data coming out about the drugs, even though we're throwing epinephrine, we're throwing bicarbs and calciums left and right. Is there any evidence to really support us using all those meds? Or are we just doing it because it's on the code card and it's available? So I just appreciate a study that perhaps gives us a little bit more evidence one way or another as to the use of all these medications in the setting of such a complex situation as you've been describing.
I have to follow that up, Marcus, with one of the things I get concerned about with epinephrine. By the time they come in to me, a lot of times, if they've worked them really well, they're 10,000 micrograms deep in epinephrine. And I'm sitting here thinking to myself, even if they were doing perfect CPR and able to maintain a cardiac output of 1.5 liters per minute or something, just something, how could their brain possibly be getting blood flow with that much vasoconstriction over 20 minutes or 30 minutes? And so that's where I think, as we've talked about before, I have a lot of concerns that the gargantuan doses of epinephrine, they were just basically turning their bodies into, they're shriveling up with vasoconstrict. And it makes me wonder, okay, now we're just going to add more epinephrine in sooner, and then we're going to give all that other epinephrine we were given anyway. Those are the kind of concerns I have. Because at the end of the day, when it's your loved one, you want neurologic survival. That's what we're going for. We don't care about just ROSC. Like, sure, we can high five ourselves and feel good about it, but we want our loved ones to walk out of the hospital.
This is where we're at based on the literature we've got. I think it's that simple.
Yeah.
You can argue for or against, and you'd be right.
Okay, gentlemen, thank you so much. You've given me a nice memory to go back to and food for thought, and hope that we may actually bring this back. I personally think that it has benefit, and I think you're absolutely right that we talked the other day about better CPR, and we're talking about earlier epinephrine and epinephrine that actually really counts. And I think that slowly but surely we will make an impact on CPR outcomes, not just ROSC, as you say, but also in neurologic outcomes and increasing neurologic outcomes. So thank you, Marcus. And that's been a stimulating conversation, and let's see where this goes. So thank you for joining EP Talk.